This is clearly our opportunity to connect with people in our field, people we don't see all the time. There will be more opportunities, but we are going to push on because there's so much to discuss. Our next speaker is Dr. Tom Strauss. He's medical director of the Stuart and Linda Resnick Neuropsychiatric Hospital at UCLA and the Mattie Katz Chair in Palliative Care Research and Education. He's also a professor of psychiatry, but he is so much more than that. He is a real expert in the treatment of individuals at the end of life and at palliative care. And he was a cornerstone of the large work group at UCLA that helped develop the policy for the way that that health system approaches the End-of-Life Option Act. He has a lot of insight into the individuals who make such requests, and that's what Dr. Strauss is going to talk with us now. And with that, I will ask Dr. Strauss.
Thanks so much for the opportunity to speak. Tony Bach did a beautiful job this morning of articulating potential for bias or conflict, so I thought I should just do 30 seconds of that. So I am a psychiatrist, as Neil pointed out. I'm a psychiatrist who's always conflicted about choosing psychiatry over internal medicine, so I decided to spend my career working with medically ill patients, and about 5 years ago it dawned on me that that had been my solution to my intrapsychic difficulty. All the psychotherapy that I paid for didn't help me discover that, but and really, mostly I've worked in cancer. And actually, in the early 90s, I had the opportunity to leave UCLA for a chunk of time and run the supportive oncology service at a very novel 24/7 outpatient cancer center in Los Angeles at Cedars, which was doing, long before its time, what we would now call integrated palliative care in the outpatient cancer center. And that's where I became a palliative care doctor. I learned pain and symptom management from the anesthesiologists who could no longer afford to spend time talking to people and were disappearing into the procedure room. So I had an incredible opportunity there. Over that time, as you might imagine, took care often for years, in some cases still, patients with serious chronic illness. This was all well before the End-of-Life Options Act. And had two patients during that time, both men, both control guys, who committed violent suicide, not depressed, not anxious, not with psychopathology, but the kind of guys who were not going to lie around passively dependent in a bed to die. And I tell you that because that, I realized as our work group began, clearly has informed how I think about this, because I think of that as probably the worst result for everybody, certainly the patient and their families, and of course for the caregivers and for the first responders who are called to those scenes. Maybe you'll think that's relevant to this discussion, maybe you won't. My primary task assigned to me by Neil was just to talk about, pretty ambitious actually, what is the topic of, what are the motives of people who pursue it, like I would know, right? I'm going to just share with you some impressions from the UCLA first year, and specifically the folks who were referred to me as one of the small list of mental health professionals who are available when, in the judgment of the attending physician, the patient shows evidence of a mental disorder. I think that's the verbatim from the law. So now I'm going to advance super fast through these slides because I didn't mean to show you them all. So at UCLA, 100 have requested aid in dying medicine during the year that began June of 2016 and ended June of 17. 54% of them were men. 88% of them were white. The mean age was 67. 85% of them had a malignancy. Enthusiastic participation, and by this I mean of the patients, as well as of our clinical care consultants that Ann Coscarelli, who's here and he'll be talking today and tomorrow, helped create an extraordinary navigator process, which I just think is amazing. And 8 of those patients were eventually referred for mental health professional evaluation, again, based on either concern about capacity or concern on the part of the attending physician or the Ann's team that there was a mental disorder that might A, be present, and B, impair the patient's judgment. Some of you have noticed the law does not tell us impair the patient's judgment about what, just impair the patient's judgment. We infer about the request for physician aid in dying. So of those 8, 2 died of natural causes before completing the algorithm and before the mental health professional eval took place. 4 received aid in dying medicine, 3 ingested and died. 1 is still holding on to her dose as of a week ago. 1 patient suicided prior to the formal mental health eval, prior to making it through the algorithm. And 1 lacked capacity because she was comatose and therefore did not qualify. What do we know in terms of what's available? Some of this work, by the way, is done from our colleagues in this room from Washington and Oregon about the motivations. By the way, California, some of you noticed, doesn't ask, right? So the publicly reported data does not ask patients to identify their reasons, whereas if you go to the Oregon website, for example, you see patients' articulated reasons, and that's an interesting discussion for perhaps another time. So what are the common themes? As we heard earlier from the incredibly articulate panel, passive dependency, the loss of independence, loss of dignity are a form of suffering, at least for some people. So the common themes: desire to control circumstances of its own death, desire to die at home, finding intolerable loss of independence, having concerns not necessarily about now but in the future, the possibility of unmanaged symptoms, often based on personal or family suffering templates, and either now or in the future a poor, unacceptable quality of life, and the inability to care for oneself. None of these is a surprise. Probably most of you have seen this literature. This comes from Linda Ganzini and her colleagues at the Portland VA. Some similar themes from, again, people in the room today, from the Seattle Cancer Care Alliance: loss of autonomy, inability to engage in enjoyable activities, loss of dignity. And this, another bit of work by Linda Ganzini, again, is highlighting similar themes at the top of the list. I'm going fast because I have 10 minutes. And then Q&A, right? Okay. So we're skipping these. This is just the illness categories from the California website. I thought the vignettes would actually be most compelling. So I think this was actually the first person I saw under the act. This was a 6-year-old Latina woman. Latina, I guess woman is redundant. Latina, with a 12-year history of metastatic breast cancer, who now has had widespread metastases to bone and elsewhere. She actually had started talking with her medical oncologist 3 to 6 months before the law went live about her wish to consider it if and when her quality of life was unacceptable. She had very specific ideas about what quality of life for her meant. It meant the ability to garden, to socialize, to read, to crochet, to pursue her spiritual practices, which she was still quite able to do when she and I met. She had a history of depression, which I think was the reason she was referred to me. Her depression was remitted. She had no active symptoms. She had a completely clear mental status exam. MoCA is the Montreal Cognitive Assessment. She, if you want to consider it a hurdle, passed the mental health professional hurdle. This is a lady who I saw at home a few days after she was discharged from the hospital. She was a nurse, actually, had moved back to Southern California as her breast cancer progressed. She had brain metastases and hypercalcemia, and by the time I saw her, she was unconscious and never woke up. But it was really important to her and to her family that formal evaluation took place. I couldn't have predicted that, but it was actually a very profound experience for me to sit with her and them. And all I did was conclude she was unconscious and therefore lacked capacity, and that was really the end of the discussion, but it was still actually very meaningful. The third vignette, lady with Parkinson's disease for many, many years, again seeing a future ahead that was unacceptable, a lot of current suffering in the form of both movement disorder symptoms and swallowing and dysphonia, almost complete dependence on others for all things. She was an evangelical Christian and had really searched both her soul and had consulted at length with her pastor and concluded that a merciful God would not condemn her to eternal suffering if she proceeded. Her neurologist, with me in the room, required her to demonstrate that she could swallow 4 ounces of liquid, which she did, and she eventually went on to proceed with the physician aid in dying. So I think that the impressions are that very not scientific. This is just some folks we've met. Patients referred to the mental health professionals at UCLA under the End of Life Options Act describe reasons for seeking physician aid in dying that seem very similar to those reported from more formal studies from Oregon and Washington. Those reasons focus on durable health values and personal perspectives on quality of life, desire to control time and place of death, wishes to avoid prolonged disability, dependency, and future symptom burden. impaired judgment due to a mental disorder has thus far not been a disqualifier for these patients, although, as I said, one lack capacity by virtue of coma. So I think that's it for my 10 minutes, and I'll look forward to the discussion because I think that'll probably be more interesting. Thanks.
Can you tell us a little bit about the criteria for when, in your health system, when are patients referred to you? And for instance, why would a patient with a history of depression that is currently controlled be referred to you?
So that's a fair question. Our criteria are simply our attending physicians follow the law, and the law says when either the attending or the consulting physician detects evidence of a mental disorder, they're obligated, full stop, they're obligated to make that referral. And so I always ask, why are you referring the patient to me? In that case, it was a history of depression. This was a lady who had a little bit of an unusual kind of life situation. I think maybe underneath that was perhaps some unease about, how does she think about this, and maybe just wanting somebody else to evaluate how she had been thinking about it, although Anne's team had done that thoroughly already. Again, this was very early on, so maybe some of it was just the jitters. I want to add, while the mic is moving, these have all been in very profound clinical interactions for me, and I've been doing this a long time, so you could wonder if I'm a little desensitized, but very intimate clinical encounters with these folks, and maybe part of it has to do with their valid concern that I and my colleagues who are doing this might actually be an obstacle to their self-determination. Don't know. Yes.
Thank you, Dr. Strauss. I'm also a psychiatrist and palliative care doctor, so your comments in the beginning resonated with me.
Right on, man. There are very few of us.
Keeping it real. One of the studies that you didn't mention, which I'd love to get your perspective on, looked at attachment styles. And this is also data from Oregon. I wonder if you're familiar with the study, and if you might comment on whether or not that study seems consistent with what you've experienced at UCLA.
It is. I think the attachment styles data helps me understand particularly the highly controlled and focused and methodical, generally men, some of whom will not even tolerate the 15 days of being dependent on us to go through the algorithm. And I guess that leads me to think, I think there probably is some subset of patients who aren't going to do that, or are going to do it, but if they find it all frustrating, they say, never mind, I'll take care of this on my own. I don't really need you people. But what he's referring to is that there is a pattern, or at least this assessment really described folks who had often complicated life stories that included not much intimacy, unreliable others, abuse, neglect, and other kinds of treatment that might make it hard to trust, particularly if you're passively dependent, like in the advanced stages of an illness. And again, it helped me understand some of these, particularly men who seemed very rigid and were not going to adapt their heads around what their illness was requiring of them. I don't know if you want to comment any on that, but.
Question about another piece of data from Ezekiel Emanuel of surveys of people longitudinally over time, kind of changing their mind when you check in with people at different junctures in their experience of illness. And I was wondering if you mentioned that these were often kind of durable healthcare values that you saw in these patients, but if you ever had the experience of kind of evolving attitudes.
Yeah, I think, and I guess what I would say is, the old platitude about, I was going to try to boil it down, but I think some people do have profound change in the context of serious illness in the last weeks or months of life. I don't think it happens very often, but I do think it happens. And I think those are sometimes people who end up landing in a very different spot than they thought they would a week or a month or 6 months previously. And in this case, maybe those are people who have the prescription and never use it, or, and Anne will speak to this, who begin the algorithm and conclude that when the impossible taboo topic of contemplating my mortality and talking to my loved ones about it suddenly is given air and openness, all of a sudden it's not nearly so terrifying. Those are just crackpot theories, though. Yeah.
Thank you.
Thank you.
So this session is on how the End of Life Option Act affects physicians. both in how it affects their decision-making, but also how the process affects them. For this, we have 3 physicians participating. In the middle, we have Dr. Chris Lillis, who I think will speak first, from UC Davis. He's a general internist who sees patients there in the Davis Medical Group. Lynette Cedarquist is at UCSD. She's a hospice and palliative medicine specialist and a professor in the Department of Medicine at UCSD. And Stephanie Harmon, at the end, I'm getting feedback, is medical director of palliative care services at Stanford and associate program director for their internal medicine residency program. So perhaps Dr. Lillis, do you want to speak first?
Sure. Thank you for having me. So I think it's important to kind of give you guys a flavor for who I am. And I wanted to start with a quote. So this is a quote from Hunter S. Thompson. Life should not be a journey to the grave with the intention of arriving safely in a pretty and well-preserved body, but rather to slide in broadside in a cloud of smoke, thoroughly used up, totally worn out, and loudly proclaiming, "Wow, what a ride." How has this influenced me? I've helped about a half a dozen patients now since the law became enacted. And it's one of the most deeply moving experiences that I have in primary care. I've been seeing patients full-time for 13 years, most of that on the East Coast, so this opportunity never presented itself. I went to medical school at Georgetown, and at Georgetown we had an ethics professor at the time named Edmund Pellegrino. Everybody's nodding their heads. So Dr. Father Pellegrino impressed upon us the importance of autonomy. But interestingly enough, when we were discussing this years ago, he was not at all for physician-assisted suicide. That was not his position, I think largely influenced by his Catholic faith. But for me, when I think about what I'm going to do if I'm confronted with a terminal diagnosis, I've got some pretty well-formed ideas about how I want that to look. And I really don't want anyone to take that away from me. I feel like it's my job as a clinician to help facilitate what my patients desire, and that obviously has some caveats and limitations. What I've done when I've approached patients who've sought the End-of-Life Option Act is I kind of go through the well-thought-out checklist, the algorithm of approaching these folks. And there have been times when I've met a patient where I felt like their pain was not well addressed, and I kind of asked them to put the brakes on and say, why don't we try to work with hospice to make sure your pain's under good control, and maybe that changes your mind about how you want to proceed. I've not had the opportunity to see many patients with mental illness. In fact, I've not had to ask for any mental health consults with the patients I've helped. But really the one experience that stands out was that patient who was in really excruciating pain when he first requested the End-of-Life Option Act. And I said, well, let's think this through. Let's find a way to palliate your pain, and then let's see where your opinion is. I know Neil asked us to think about the practical concerns when we talk about this. And I will say, while it's one of the most rewarding things I do in my practice, it's also one of the more time-consuming things, and I think that's appropriate. To the last speaker's point, this is a very intimate encounter. We learn about their life, their hopes, their dreams, their fears, and that takes time. It's not something you can rush through in a primary care practice. And so I've been very careful with the help of my clinic to schedule enough time to have these delicate dialogues and best feel that I'm following the spirit of law, but also addressing my patients' concerns well. In terms of the emotional needs, I don't know. When Nathan takes me out for a beer, it works out pretty well. It is quite moving, and it does bring a lot of time for reflection and introspection. There is some second guessing, for sure. But at the same time, we're blessed at UC Davis to have a robust team to consult with and make sure that we're following not only the letter of law, but the spirit of law. And so Neil also asked us to think about, does the End of Life Option Act change medical practice? It hasn't for me. I feel like I practice primary care the way I always have. This is just simply a new option to help my patients at the end of their lives when mortality is on their mind, and largely issues of control and wanting to shape their destiny are at the forefront. It hasn't changed my practice in any other way that I can think of, except that these very special interactions are very different from my upper respiratory infections or hypertension or diabetes visits. Does this affect the continuity of care? Well, it certainly brings an abrupt end to the continuity of care in some cases, but no, I don't believe so. I think this is the best part of our job. This is the time when we can provide comfort when we don't have a curative option available. This is the time when we can address the spiritual and emotional needs of our patients and their families when they're in a time of deep contemplation about what they want the rest of their life to look like. So for me, the End of Life Option Act has only had a positive impact on my practice. It certainly brings a great deal of time and reflection, and I think if anything, it helps me think about the patients who aren't at the end of their life and helps me counsel them about living life to its fullest, kind of with like the quote I brought up to start this thing. But it reminds me of why we do this, honestly. So it's been a deeply rewarding experience. I'll end there.
Thanks, Doctor. Dr. Cedarquist? You
Okay,
wanna-
sure. So I guess a little bit of kind of my background with this is that I was certainly in support of this law being passed in California, and I've always believed that this is something that should be available to people if they choose it. And so I always felt that, if it was made available legally, that in my own practice and also in internal medicine and pain management, that if I believe it should be available, I should also be willing to be part of patients having access to this. I think for myself as a physician, my experience, how this has affected me, I've seen a handful of patients who were not my own patients. They were coming to me because their physicians had opted out, so they weren't patients that I had a pre-existing relationship with, which I think is more ideal, but obviously not always possible. I'd say these encounters have some of them have been the most distressing patient encounters I've experienced, and others have been some of the most rewarding. So I've had kind of two very different experiences just myself with this for a variety of reasons. But I think, so it's been an interesting and I would also say, agree, some of the most intense patient encounters that I've had, and I've been in practice 23 years, so I've been doing this a long time. As far as kind of witnessing how these requests impact my colleagues, most of whom have been the oncologists, I've perceived that it has created a lot of distress for them. Most of them, well, not most, I'd say at least half have decided that they would opt out of participating. And so this is not something they really want to be faced with or deal with. And so that creates distress for them because they really want nothing to do with this when a patient brings it up. For those who are willing to do it but have not done it before, as this is a new practice for everybody, there's a lot of distress around it. It just looks like an overwhelming process the first time they proceed with trying to help a patient. So it just feels overwhelming to them, I think. Most of them, once they go through this once with a patient do feel better and realize it wasn't as overwhelming as it looked, and really felt like it was important to them to step up and do this for their patients when they did. So again, you know, in some situations, a lot of distress for the physicians, and others, it really ended, you know, to be a positive experience for them to be able to do this. So it's, you know, it's forced physicians to kind of make that choice. Are they going to opt in or opt out? The practical concerns for physicians, certainly the sense of how much time they feel like these visits take, as they should. They should never be brief visits by any means. And our suspicion is that a lot of physicians who are opting out of participating aren't necessarily doing it out of any strong moral convictions. They're doing it because they just don't feel they can have one more demand on their time when they're in clinic under, you know, a lot of productivity pressures. They just feel like this is going to be too much if they take this on. Those are the ones that, you know, I would hope can evolve over time to be able to take this on. How should we assist physicians who are faced with this? I mean, I think a lot of our institutions have trained and developed aid and dying care coordinators, which I think has helped our physicians immensely to have somebody who can just show up, help the patient walk them through, help the clinician walk through the whole process, has been an immense help for them. As far as supporting physicians, their emotional needs, when they do get involved with patients who are seeking aid and dying, I think that's still something we have not addressed at our institution, and I'll be interested to hear if others over the course of today and tomorrow have been able to develop some way to support these physicians. Like I said, probably two of my most distressing patient encounters were around this, and you know, it's kind of, you just tuck it away and keep going, but we all know those kinds of experience do collectively start to affect us over time, and maybe there should be some mechanism to address our suffering when we experience that. Let's see. Does this change medical practice? Well, I think it does for the physicians who do get involved or are being asked by their patients. This is a very emotionally charged, intense kind of care that we're being asked to provide. So yes, when you get involved in providing that, I think it certainly changes medical practice. And the other, I guess, kind of unanticipated effect of this being now legally available is, I think the most distressing experiences I had were patients who were suffering immensely but did not meet the less than 6-month prognosis, and they felt that they were being discriminated against, that their suffering didn't count, and were very distressed, whereas, you know, a year ago or 2 years ago when this wasn't even available, we couldn't even be talking about it. But now that it's available, but not to everybody, that's creating distress for those patients. And I don't know how to, what the solution to that is. Because like I said, they feel discriminated against. Effects of the Act on continuity of care. I think it does affect continuity of care because when the treating physicians who have a long-standing relationship with that person have decided they aren't participating, which we all respect their choice not to participate, then suddenly the patient has to see somebody they've never met before. And that's not a perfect solution, but it's a solution. But again, it's now fragmenting who's taking care of them as they're reaching their final stages of life. And patients who've had long-standing relationships with, you know, usually it's the oncologist, and this comes up and the oncologist says, no, I'm not going to do that. those patients do feel oftentimes a significant sense of abandonment by their physician that they've had great trust in for a long time. And again, we recognize the physician's right to opt out of participating, but unfortunately that opting out does result in patients feeling very disappointed and abandoned. And again, I don't know what the solution to that is. It's again, I think, an unintended consequence of somewhat disrupting those patient-physician relationships that we have to find some way to contend with. So those are my thoughts in a nutshell.
Thanks, Dr. Silverstein. Dr. Harmon.
Sorry, there we go. All right. So I'm Stephanie Harmon, and to say a little bit about kind of my perspective, where I'm coming from. So I'm a palliative care physician. I also co-chair our hospital ethics committee and helped write our policy around the process that we follow at Stanford as a participating institution. And I think one of the things that I had talked with Neil about was trying to seek the perspective of a physician who's opposed, who is opting out of participating. And so in that process of trying to find someone for this panel, I essentially conducted a small mini qualitative study on what perspectives physicians were opposed at Stanford. And so I wanted to just share that briefly. I think the spectrum of perspectives actually surprised myself and our kind of operational group that's been working on physician-assisted death. And then I will just add my own personal piece as a palliative care physician. So the first, I think, that was articulated by a number of physicians was their sense of a moral objection, and explicitly, quoting and referencing the Hippocratic Oath. And so that, that thing that we all recited back in medical school, and to see this in multiple messages, and we had 19 town halls prior to our institution making a decision around participating, and so, and hearing this articulated, this was one of the main perspectives our physicians who are opposed took, that it was a matter of conscience for them. The second perspective that I had elicited was one of physicians who didn't feel that they were theoretically opposed to the law or the legislation. However, they viewed it explicitly as a very much a last resort option, and that clinically speaking, they didn't think they'd actually practically reach that point for their patients, that they were more confident in their other, basically other options to provide care for patients. And so while that was, it was more kind of functionally leading to opposition or not participating. The third kind of echoes what Dr. Cederquist mentioned about the kind of the operational burdens of participating. And so I talked to one oncologist who had gone through the process for a patient who didn't have a physician at Stanford, whose primary care physician was a family member, and they didn't feel comfortable going to that family member to pursue this end-of-life option for them. And so they had no insurance. They were coming in privately to our health system. They didn't have a kind of a designated caregiver or family member that was with them. And they came, and this oncologist who had been offering to participate and help patients who don't have a physician who's willing to prescribe literally felt, and the word she used was cornered. And this added pressure of kind of this patient's functional status declining, and I think those operational burdens for her were too much, and after that explicitly decided that she would not participate any longer, at least for patients who weren't her own, and had a lot of misgivings about the whole process after that experience. And she had a partner, a social worker, who had been working with her, who also had this feeling of being cornered, and that because of issues around kind of secrecy and privacy, felt very isolated in that process. Lastly, Another perspective had been one that was framed to me as a public health perspective around suicides and looking at what happens to suicide rates in areas or in states where physician-assisted death is legalized. So not those explicit deaths, but looking at suicides, and they expressed concern after some basically observational data around an increased number of suicides. And I think that that was a perspective I had not been as kind of shared as frequently, but I thought that was an interesting one and one that was kind of a departure from what physicians were taking on as their own practice. And then lastly, to speak for myself, I think as a palliative care physician, I've been doing palliative care at Stanford for the last decade and had been the founding medical director. And the challenge we've had at Stanford in our culture around palliative care is disarticulating kind of this concept that palliative care will hasten death and will lead to withdrawal of life-sustaining treatments and disease-directed therapy and will suck all the life from a patient, their family, and the physicians. And it's been kind of moving against that in a gentle way, kind of like orthodontia, that to have this, well, until recently at least, this my own perspective around prescribing and that association directly with the End-of-Life Option Act, having just last week heard a cardiothoracic surgeon say, when I hear palliative care, I immediately think you're going to withdraw life-sustaining treatment and any aggressive therapies on my patient. And so that's been my own kind of personal practice. In our system, palliative care physicians actually don't prescribe because we're actually embedded as the consulting physicians. So, and I think my one comment around effects on practice, so I've heard from physicians who I don't think had been in the practice of asking around what patients' wishes are at the end of life, remark that when someone asks them about the End-of-Life Option Act, they ask, why are you asking that? And that's been a change in practice for some of our physicians, and so.
Thank you. Before we open it up for questions, let me ask the three of you. I think all doctors at times, especially from patients that are more controlling or want to have control of their medical care, they will sometimes request treatments or diagnostic imaging or something else that is not indicated. And we as docs, under those circumstances, have certain responsibilities to resist providing such treatments. Do issues like that arise concerning requests around the End-of-Life Option Act? Are those similar concerns coming through?
You mean that physicians interpret the request for 8 and 9 as something that's not indicated, that they shouldn't be obligated?
Inappropriate, something the doctor shouldn't be prescribing.
Well, I think that would be, again, based on the own physician's own personal values, that they don't believe that this is something that patients should be asking for and that physicians should not be obligated to provide. I think it would be maybe fall under that kind of similar concept.
Yeah, I would say that that sense of feeling cornered is something I think we've all felt for a variety of different reasons. Thus far, I have not felt that way about the End-of-Life Option Act, I think because I've been one of the champions on the primary care side. A lot of the referrals that come to me are already screened by our navigator, already screened by our palliative care docs. But when we have to kind of take the time to carefully explain why something's not indicated, that it really can result in a poor interaction if not handled very, very carefully. So I usually find myself taking some deep breaths, stepping back, explaining the criteria for the law, I think, so educating the patient is really paramount in that interaction. It's no different than if a patient's requesting an inappropriate imaging study. Our job as educators really takes the forefront at that time when there's an inappropriate request. And trying to make sure that I'm articulating in a very obvious way that I've heard their concerns, I've heard about their suffering, I understand what it is that's causing them distress, but then following up that validation, that verbal validation with education about why something's appropriate or inappropriate can often, not always, but often lead to, an amicable resolution and significantly help reduce the distress my patients are experiencing. So whether it's an antibiotic or an imaging study or the End-of-Life Act, I think I approach it the same way. It's a matter of pausing, getting to know what the symptoms are, the distress is, validating that carefully, and then stepping in as an educator and letting patients know, what's appropriate and what's inappropriate, usually brings a reasonable resolution to those encounters.
I think I would only add that we've actually had more requests around things like diagnostic tests, more from physicians who are seeking additional evidence that their patient does have a prognosis of 6 months or less, who have had either a very chronic kind of relapsing, remitting course of their illness, and are seeking guidance around that versus that diagnostic test to allay or preclude a patient's opportunity to participate. So.
Working? Hello? Yeah, okay. Hi, this is Liz Zhang. I'm from UCSF. This question is actually for Stephanie. You bring up a really interesting point, an important point, I think, about the tensions between palliative care, trust, and perceptions. I know that it's only been a year, but from your early experience, given that at Stanford, palliative care providers work, are in partnership as the consulting physician, have you noticed any shifts either from the provider standpoint or from patients of that sort of, palliative care then having the risk of becoming more associated with some of the things that you were concerned about?
I'm not sure. It's very difficult to tell about major shifts. I think what I did hear in the process was from clinicians, physicians who were opposed, and that kind of spanned many different specialties, an ask actually for the policy and for the executive leadership of the hospital to consider palliative care as a, actually encourage the use of palliative care as a way to ensure that patients and families have access to other resources. Just practically speaking, at our institution, our clinics and our service we have more social work support and chaplaincy and other services built in, and that was an important thing for some of the physicians who were opposed to see that included in the policy once the decision was made to participate.
So I want to ask a question against the traditional medical morality that was referenced, but just sort of in passing. Because I want to ask two things. I want to ask if you think that your positions in the areas that you practice, the community of physicians that you work with, if you're in the minority, such that there's still a majority hold the traditional morality, whatever basis that is, because we could look at the history of the Hippocratic Oath. It's very interesting, but it's a minority view at the time, and yours is maybe a minority view at this time. So the question is, do you think that there is a moral basis or a social basis to support your decision to have this professional relationship with the patient? Because I hear that it's a personal decision on the part of the physician, but it also changes in terms of the understanding of the social relationship sort of in the society and also the scope of responsibilities. So I was wondering if you could explain how you understand that in terms of your responsibility as a professional, not just to the patient, but also to the profession.
In regards to, I suppose, the opposition based on the Hippocratic Oath of do no harm, I didn't really explain my full role at UCSD. By the way, I'm director of their clinical ethics, so kind of do try to approach this from a bioethics analysis basis, and have done many years of hospice and palliative care. I think we know most of our job in medicine is palliation, especially in internal medicine. Palliative care, there's very little cure, and we palliate. And we do everything we can to minimize suffering. And I very strongly believe that allowing access to aid in dying is with the same goal of reducing suffering at the end of life. Should be a last resort. We should do everything short of that to alleviate a person's suffering, but we all know there's kinds of suffering we cannot relieve. And so I think it's ethically very well-founded practice to allow this.
Yeah, I would say that as institution, as we started to look at our policy, I was surprised that I was in the moral minority. I think that a number of our physicians don't feel this is something that they can do morally. But I mean, I would agree. I've kind of worked through the ethics. I've done some soul searching, and I feel like this is a word that came up, and it's very important, is that concept of abandonment. I really do feel like when patients are at this point where they have a terminal diagnosis, where hopefully their pain is well palliated, but they still feel like they want to have some measure of control in how their life ends, I don't think it's morally right to deny that request, especially when this option is available. So that's, I'm not sure if I fully answered your question, because you were commenting a little about societal implications as well. And I think that a lot of docs don't really think through the moral implications, societal implications of what this means. I think there are more pragmatic concerns regarding time and paperwork, and regarding kind of the comfort with the accuracy of the terminal diagnosis. And so many of those, I think, get in the way of even considering the morality of this. Yeah, because, as a primary care doc, I can tell you, when you're hustling through your schedule each day, you're not having a lot of time for introspection, reflection. You got to do that on your own time.
I want to appreciate the candid expression of both ambivalence and conviction represented here. As a primary care physician at Stanford, thank you, Stephanie, she's been a shining light. I wanted to say that I do think that it changes our practice in primary care in a profound way, which is that many conversations do not lend themselves to short visits. And this one, like many that we do, requires time and thought and absolute mindful presence. And so trying to find that makes you realize all the other ways in which we circumvent good care. I mean, in the same day I saw somebody with this very conversation, I also did an intake for someone who had a domestic violence documentation, and I can tell you right now, I felt completely conflicted in my role in so many ways. And so I want to just appreciate that this is a complex issue, and people move slowly as they navigate something that is legal and that people have conflict about, and have some compassion for that very slow process.
Hi, thank you for your insight as physicians. I'm Connie. I'm from Hines Hospice in Fresno. And my question for you is along the lines of, as a hospice and palliative care provider, one of the challenges we find are patients coming in, or patients in the community whose message they hear There's nothing else I can do for you, so I'm referring you to hospice. And what does that communicate? That communicates to these patients, well, they're not going to do anything for you. And I struggle a lot with that, that message. We know that our general public, where are they being informed? Places like, Facebook and things that aren't the most reliable sources of information, right? And so when you have that, well, I either have to suffer or I have to participate in this end-of-life option. Have you encountered patients that maybe needed more education along the lines of what hospice and palliative care can provide? And how did you respond to that? What's your mode of education for them?
Well, so far, 100% of the patients within our institution that have sought aid and dying, if they weren't under active treatment, they were all already on hospice care. So it wasn't, I want this and I don't want hospice. Every one of them has had that in place, so we haven't had to deal with that. But yeah, I don't think this should ever be a replacement for getting someone onto good hospice and palliative care. That should certainly be in place first.
Yeah, and the one patient I alluded to who needed probably a little bit more in terms of education about palliative care before we got to the point of prescribing. He enrolled in hospice weeks before he came to me, and didn't even know what was in his comfort kit, didn't know that he could take certain medicines for pain. He was writhing in pain, and so that first encounter, it was really not about the End-of-Life Act at all. It was all about education, about, no, this is what hospice can provide. We can help your pain, we can help your spiritual needs, we can dispatch a chaplain, we can help your emotional needs, we can help your practical needs. And so, again, that role as educator is paramount, I think, when there's a little bit of a disconnect between what the patient perceives and reality. And so that's part of my intake when it comes to a first oral request, is understanding how they're interacting with hospice and are they maximizing their benefits. Because if they're not, that can heavily influence whether or not they wish to proceed with the End-of-Life Act or not.
I would just echo that, and seeing patients in both an inpatient and outpatient setting. We have a number of, remember one of the early cases, actually patients who had made a request to their physicians, had a KO feed or a Daboff tube in, and had assumed his existence would be the rest of his life with this tube down his nose, and it was like this was no way to live, and you don't have to keep that in. And it changed the conversation, and it was also something, interestingly, that the train of kind of continuing these kinds of treatments was so strong. It was like the TGV. It was like, it's got to go this way, that kind of education on hospice and palliative care had been missing.
In some of the breakout sessions, I want to thank Drs. Cedarquist, Lewis, and Harmon. Thank you very much.
Good afternoon. I'm Shirley Otis Green from the Coalition for Compassionate Care of California, and we're delighted to have this opportunity to speak with you. Everything else up to this point has been a lead-in. We are really the most important group. So we just want you to take that into account. We're going to talk about the impact of this from a psychosocial, spiritual place, and the impact on patients, on families, on providers, on janitors, on gardeners. We're going to look at the whole gamut. And I really think about this in terms of the unintended consequences of being mortal. That's what this entire End-of-Life Option Act, I think, is about. And so with that in place, I'm going to ask each of my colleagues here to introduce themselves very quickly, and then to spend just a few moments kind of setting the tone and looking at the impact, again, of this from a non-physician perspective. And as you can imagine, we like being defined by what we're not. So we're going to remind you that that's really from the point of view of social work, psychology, nursing, again, from those specific disciplines, and coming from different perspectives. So with that, Anne?
Hi, I'm Ann Coscarelli. I'm a psychologist by training. I'm the Darcy Dent-Kurtnakin Director of Psychosocial Oncology Care and a whole bunch of other things at UCLA, and have been part of the workforce that helped establish the policy at UCLA. And one of the things that we did at UCLA, let's see, I'll make sure I can know how to advance this. Okay, was that we set up something other than the mental health specialist role that Dr. Strauss was talking about, which was we developed a role called clinical consultants. And I'm going to talk more about that tomorrow, but one of the things that I wanted to note just for today's presentation, because it's partly what I want to address, is that as clinical consultants, we serve patients, families, physicians and the medical team, as well as the healthcare system. And so I wanted to kind of make my psychosocial comments related to those various categories. So I thought I'd start with talking just a little bit about for patients. Many of the patients that we talk to talk about an insurance against the potential suffering, loss of dignity, quality of life, and I know that those terms mean different things to different people. Many people say that they don't know if they'll use the drug or not, but they want to have it in their possession. And I think that's an important thing to differentiate, because it is an anxiety reducer for those patients in many situations. The other thing that comes up is a lot of disappointment and distress around not being able to qualify. And not being able to qualify can come from they're so advanced that there's really not enough time for the process to move along for them to actually get that drug in place. So in a quaternary care center where we are, people come from other states, so they may not be residents in California. Patients may not be able to absorb or ingest the medication because of something that's going on with them. Or they're coming from institutions that are not participating in it. And at UCLA, we don't simply take patients who have decided to come here only for that purpose. And so there can be a lot of disappointment and distress on the part of patients, as well as difficulty in commuting from appointments. But one of the big things is, I think, in the interaction, the psychosocial distress that comes in the interaction with the physicians. And for a lot of patients, there's fears of being abandoned if they bring up and talk about this with their physician. And so that creates a certain amount of distress. Another piece of that is that physicians may have conversations about the End-of-Life Option Act, or death with dignity, as many patients refer to it, not realizing that patients are actually making a request. And you go back and you look through the charts, and there's no notes in the charts. And I think there's this disconnect between what is a request, what does a request even look like? Is talk a request? Is talk a conversation? And I think these are some of the important things to think about. The other is this fear of rejection of the request. And I've heard patients say, I'm afraid to ask. What if he says no? What if he thinks I'm not invested in getting well? Because I think most of these patients have this experience of being very invested in wanting to get well, and they don't want their physicians to give up on them, but they want that insurance. And so that creates a certain amount of distress that comes up for them. And of course, then there's different appraisals of where they are. There are language barriers that come up in trying to deal with this very complicated process. And then there's also misinformation. And all of those things can lead to psychosocial distress on the part of the patient. For families, what I've seen is I've actually seen a lot of what we heard today in the panelists, which is more benefits to the EOLOA on bereavement. They feel like they honored the patient's requests. They had the opportunity to say everything that they needed to. They didn't want their loved one to suffer, or that their family was together at the time. And I think that's a very important piece of this. I put on here that patients and families don't always agree on the process, but that's more of a place marker. It's not something that's been a strong position. And then I brought this one vignette to read. I have an observation complaint about how her aid in dying request was treated, not kindly by Dr. X. Perhaps he took offense when my beloved was feeling that he was not being compassionate a number of months ago and requested a second opinion. She knew her own condition was not improving with treatment, but getting worse. The cancer markers had risen steadily every month into the 1500s. She knew she was failing and didn't have and didn't have to go through those scans. Yet her medical personnel chose to delay her approval until they were really sure she was going to die. It was no longer her imagination. And in that period, if they're delaying, she deteriorated very quickly, so that by the time she had the meds, it was impossible. Now she was too sick. So that you get a flavor of some of that in the bereavement process, some of that sense of regret. Now, I also recognize that that sense of regret is part of normal grief, and there's many things in that which we could talk about. And then the last part is we spend a lot of time with physicians, and so we are involved in the process of helping them to do the regulatory piece, but we've also been involved in some of the reflections and self-reflections around whether they're going to participate or not in this. And this has been an area, I think, of interest where we are actually talking with patients about, or physicians about their distress in this process. And so I think a lot of people, as we've just seen in this panel, there was some struggle about whether you're going to participate or not. And there still is probably more people that are not participating, at least as the attending physician in that role. And then one of the things that we've seen is that physicians who change their position, and I think this quote, after I said no, I would not be the attending the first time, I realized later that I had abandoned my patient and disrupted our relationship. She had understood that I would care for her until the end, but I didn't. Now I see it as one option in care, and I participate because I believe in not abandoning my patients when they need me the most. And so there was a lot of psychological distress around that process for that particular physician, and I've heard a number of people who have said that. For staff, there's an urgency that if the patient makes a request, someone's got to see them immediately and get that happening for them. Otherwise, they feel like they're letting them down. And so this real fear of worries and things. And then this issue of worries of being judged by colleagues. You won't tell anyone else that I'm doing this, right? So not wanting that judgment to be out there. And I think the fact that there were so many physicians who have spoken openly about participating, I think that's always a good thing, to take away that sense of judgment. I think no one wants to feel judged. I think patients, physicians, any of us probably sitting in this room. And then understanding patients' fears about it. Why would a patient, sometimes we've had physicians say, why would a patient be afraid to talk to me about this? And so just helping them to understand that and to talk through this. And then there's lots of fear around making mistakes. Like, I've never done this before. What if I do it wrong? What if I don't follow the regulations properly? Or what if I'm wrong about the prognosis? And so some of those things, I think, create psychological distress for the physicians and the medical team. And then also just managing the expectations for patients and family members about what's involved in the process and how complicated it can be. And actually, I hate to keep using complicated. I think it's just, it sometimes takes longer than what people want it to. And then lastly, I'll just comment a little bit on being in this role as a psychologist. You know, I really see it, I think in our keynote address, he talked about it being the gateway to end-of-life conversations. And I love the term gateway because we hear that so often as things that are the gateway, like gateways in terms of drug use. But this is it. This really is where the door just gets like opened, and then there becomes this opportunity for conversation. And I think that's one of the really beautiful things that have come about as part of this. And so, I'll say a few more things, and then I'll let the next person speak. I think involved in sometimes the difficulty in explaining why you want to pulse even when you're having aid in dying medication. So getting to some of those conversations, or acknowledging the difference that when you're saying goodbye to somebody that you know is going to go home and ingest is different than when you leave on a Friday afternoon or after some visit with a patient and you don't know whether they might still be alive and you might have that next meeting with them. And so there's something different about the qualitative nature of that. And then in this role of clinical consultant and as a psychologist, uncertainty about the death and whether the patient took the medication, not knowing when you may not be in contact with patients regularly, and what happens to people, if they don't check in regularly with you. And then also, one of the things I think from a psychological perspective is just thinking about what are we invested in? You know, what are we advocating for? And sort of checking in on that, and what are our hopes in this process? And I think that it's important that we allow those hopes to shift with our patients and help us in that process. And the last thing I want to just say is that we have a group that we meet regularly to talk about these things, and we, as part of that, acknowledge every patient that goes through the process and acknowledge the deaths. And in that way, we build some meaning around that for ourselves as we're going through that, and managing sometimes the more difficult deaths, or the patients whose wishes were not met and that they were not able to obtain the drug even though they very much wanted to. Okay. Yeah.
Good afternoon. My name is Russell Kiefer, and I'm the Regional Director for Palliative Care for Providence Health and Services in Southern California. So I'm representing a non-participating organization. So my thought when Shirley asked me to speak was I could say, we don't participate. The end. Any questions? But really, there's more to it than that, and we're called to do more than that. And so what I want to talk to you about a little bit before we even go further into psychosocial issues and perspectives, because our interface with patients around this topic is different. It's different as a non-participating organization. So what I want to talk to you about is what it means to be a non-participating organization, and specifically what it means for Providence Health and Services to be a non-participating organization, because I think regardless of the stance, we are called to respond. So I pulled an LA Times quote from before the legislation went through in May of 2016. A brief quote. For some religious hospitals, the new law can be as contentious as birth control. Providence Health and Services, which operates 6 medical centers in Southern California, said it would be opting out because the law is incompatible with the system's Catholic beliefs. We at Providence believe intentionally ending a person's life is not consistent with core principles of the professions of medicine and nursing, said a Providence spokeswoman. We are committed to providing appropriate support for dying persons and their families through the final stages of life. We will not be present if a patient chooses to ingest life-ending drugs, but we will work with the patient and the loved ones to discuss the plan of care, she said. So to kind of dive a little bit deeper into that, Dr. Glenn Komatsu, who's in the room today, who's our regional CMO for hospice and palliative care, developed 15 talking points for our staff and caregivers at Providence specifically around the issue. And I do want to read some of those talking points to you today. I'm not going to go through all 15 of them, but again, I think this helps set the stage and also talks about our response. We in Providence are excellent providers of hospice and palliative care. We will never abandon our patients, families, or colleagues in end-of-life circumstances, regardless of their interest in physician aid in dying, and we will continue to provide excellent hospice and palliative care. We will be able to discuss all moral, ethical, and legal options with patients, families, and colleagues in an end-of-life situation. As provided under the law, Providence has chosen not to participate in physician aid in dying. This includes Providence facilities, programs, physicians, and healthcare providers. If a patient wishes to pursue physician aid in dying past the discussion phase, the provider may refer the patient to the organization Compassion and Choices. The provider may make this referral based on conscience, as the referral does not reflect support of the law, but rather the patient's right of choice. Providence physicians will not attest to the 6-month prognosis, signing certificate of terminal illness for hospice certification or recertification shall not be used by the patient to satisfy the requirements of the End-of-Life Option Act, nor prescribe the lethal dose of medication for this purpose. Patients who choose physician aid in dying will not be discharged from Providence Trinity Care Hospice or Providence Palliative Care Services solely for this reason. And patients who choose physician aid in dying will be asked to keep their hospice or palliative care teams informed of their progress and plans for ingestion of the lethal medication. Patients will be informed that Providence physicians and providers will not be at the patient's residence at the time of lethal ingestion, but that Providence physicians and providers will continue to be on call and available to assist our patients and families in the event of a complication or to make the customary bereavement visit after the patient dies. Providence physicians will complete the patient's death certificate with the terminal illness as the cause of death and not physician aid in dying. Those are the high points. So while presenting psychosocial concerns are common among our patients regardless of our position, the request for the End-of-Life Option Act should be considered an invitation to further explore fears and wishes rather than a conversation stopper. Clinical social workers, psychologists, nurses, and chaplains have fielded similar expressions of wanting to die for many years, and we are uniquely qualified to lean into these conversations. The End-of-Life Option Act requests are one of many ways that patients bring up concerns about their care needs, and providers can collaboratively reflect on a whole person-centered view of moral, ethical, and legal considerations in treatment planning and eliciting goals of care. Perhaps the single most important response that clinicians can offer to their patients is a willingness to engage in the discussion.
Hello, hi. My name is Leah Morris, and I am here. I'm a nurse practitioner with EOLOA Hospice and EOLO Care, which is a palliative care program. We're based out of Davis, California. We serve about 5 counties, and our census in the hospice side is about 95 patients, and our census on the palliative care side is about 50 community-based patients. When Shirley invited me to be on this panel, I felt that the emphasis was a bit on the experience of the team members who have been involved in some of these care circumstances. So I thought I would talk to my team members and get a little bit of feedback from the social workers, the registered nurses, and the spiritual care counselors, as well as our bereavement manager, to find out a bit more about how these experiences have touched our staff. Again, our census is fairly small, like I said, about 95 patients. When the End-of-Life Option Act was being debated and then passed and signed by the governor, our small organization had some thinking to do about what was our role, how would we deal with any questions and concerns that came up. And I also have a bit of a policy hat. Some of you I've met before when I worked with the coalition for about 1.5 years, and so I took on the role at EOLO of trying to help devise the policy for EOLO Hospice. And we came to a somewhat neutral position, if you will, which was that we would educate and support families that were involved in a decision around the End-of-Life Option Act. We would welcome any patients to be on our service and would support them. However, our medical director was not in the position to be acting as the attending or as a consulting physician. She works full-time as an oncologist at the University of California, Davis, and her role was more not in the position of being the attending or the consulting for patients at EOLO Hospice. So that sort of removed the discussion about whether we were engaged in directly any activities about whether someone qualified for the End-of-Life Option Act or the prescribing of the medication, aid in dying drug. However, we felt that we needed to know about patients who might be coming on service And so began a process of how we would ask patients and families about this. And in the past year or so, we've had about a dozen patients who have used the aid in dying drug. I have to say about because there have been a few cases where the family did not disclose to our team that that was the circumstance that was the end of that patient's life. They felt very, very private about that decision for probably all the reasons that we've talked about today. Fear of being judged, or just privacy, or just wanting not to have anyone in the outside community know about it. So we have some cases where there was a call for a nurse to come and pronounce. It was not entirely expected given the patient's condition the day before, and because we knew that they had the aid in dying drug in the home, but they did not reveal that to our team. We had also circumstances where our team members have been present in the home, and in our policy, we went through a fair amount of dialogue about if we were going to support and provide education to families, how would our team members possibly be involved in any of that education and support, and did it come down to being present in the home or in the room at the time of ingestion. And our one of our board members, who was a physician who was a prior medical director of our organization, said, I think it's all right for our team to be there, but there must always be at least 2 members of our staff. If one is going to be there, we want 2, so that there's no confusion about what activity our staff member did or didn't do. So everyone agreed and felt comfortable with that. We've had often 3 members of the team, the spiritual care, the registered nurse, and the social worker present. And they've provided as much support for each other, as it turns out, as for the family and the patient. That support has sometimes been after the fact, back at a debrief in the office, but it has been incredibly important for the teams to be together and to be helping each other and supporting one another. There's a couple of things that have come up that we've wondered about, we've thought about. In this area, again, I'm out of Davis for EOLOA Hospice. We serve, there are about 4 healthcare delivery systems that serve the population. So the UC Davis system, we've had 1 patient, I'm pretty sure only 1 patient from the UC Davis system on our service. We have patients from the Sutter Health System. We've had a few from Sutter Health System. We also take patients from Kaiser. They have somewhat of an overflow on their hospice program, and we've had about half of our end-of-life option act patients have been from Kaiser. And then others who are somewhat scattered with other sources of care that they've had. And so mostly Kaiser has been the main resource that we've learned a lot about how to work with the families. And 2 cases I thought I'd share. Of the first actual case that we had, all 3 of our team members were present. The loved ones for the individual patient were very much on board and very involved in being supportive to this loved one. The family members were trying to open the capsules to make the slurry, and their hands were shaking so much that a capsule or 2 fell on the floor and rolled under the stove. They looked at our nurse and said, is there going to be enough? Do we have to stop? And she, probably unknowing what to say, just said, oh yes, it'll be fine. As it turned out, it was fine, but after the fact, everybody was very worried about what may or may not happen. As it turned out, in that circumstance, that woman wanted to take a shot of whiskey after she had her slurry, and I kind of think that's in the Kaiser protocol that they might want to do that. The family all had their shots, and they all, okay, I'm getting to know, they all had their little shot of whiskey, and the patient died within about 2 minutes and 20 seconds, and she wasn't able to have her shot. So the family was comfortable, and our team was comfortable even though a capsule had rolled away. The other circumstance was a family where, as it turned out, the team that was involved were the social worker and the nurse, and the family was not interested in having a chaplain involved. The social worker and nurse were both personally not supportive of the End-of-Life Option Act, but we didn't know the circumstance as the patient was coming on service. Then the social worker and nurse wanted to not abandon their patient. Both were absolutely passionate about caring for this patient, had developed connections to the family, and were very engaged in supporting the family and not in any way abandoning them. The family did not want the person to have the death in the home. So someone had found out about an assisted living facility that would allow a patient to be there for a one-night stay and do that at the facility. So we thought everything was pretty smooth. When it came to it, the family members were very distressed, as it turned out, and then we're turning to our team members to help them create the slurry. Our two team members were very anxious, very concerned, and it turned into quite a distressing moment for those two team members. They felt like they couldn't hold the concoction, they couldn't help stir, they couldn't be of help in that direct way. It's made me realize I need to go back and revisit how our policy is written so that we can be more thoughtful about what it means to be supportive. But those team members were in quite a bit of distress. After the fact, now that's been a few months, I've talked to the nurse, and she, who is not supportive from a religious perspective, interestingly recently turned to me and said, after that patient had drank the slurry, she said, "Oh my God, it's beautiful." And then she thanked her whole family, and then she died. That nurse is really taking this in. I don't know if it's changed her personal perspective, but it left her feeling much better about it than what it had previously seemed like when she was describing her distress with the family being in distress. So you never know what moment might change someone's experience and how our team members at least responded to this situation. I think the slurry, I know we're going to have a talk about pharmacy issues tomorrow, because that's one of the things that's come up is the creating of the slurry, the timing of the drinking of the slurry, the medication stability, et cetera. So that's been one of the things that we wondered about. We've also been thinking about special bereavement. I talked to some of my colleagues, and we don't have a special bereavement follow-up, but we think that that's probably important. So we're thinking about developing a specialized bereavement discussion after hearing about some of these cases that others have shared. So those are a couple of things that we've learned about.
So we want to have, you can see we have great wisdom here on our panel, and we would like to invite you to raise any questions that you might have. Certainly when I hear them speak, and again, thank you for representing such broad range. I like the positive, negative, and neutral. There we go. We've got all of our bases covered. You can see that there's opportunity here for ambiguity, and I think ambiguity is so often related to distress. So that's certainly a theme that comes to mind. There's distress if you personally are opposed and you work in a place that's pro. If you're the opposite, if you're pro and you work in a place that's opposed, did I say that? Anyway, you see what I'm saying? Opposite sides there. It's tough when you're the patient or family member if the other, again, has a pro or a con. It's tough if you're a person in a situation, again, as you described, where it evolves over time, that I'm against, but here I am, and now I'm maybe, that's changing. So I think that there's just a lot of room here for moral distress and for psychosocial and spiritual implications from this work on every level. And I'm talking until I see a hand go up, but I'm hoping soon someone's going to do that. We've covered it so fully. Yes, please.
Is this on? I would just say that there was a missing link with hospice because there was no follow-up after the death. Never heard from hospice again, and I felt that it was a real abrupt ending to that relationship, and I was quite surprised by that. So I like your idea, support your idea, having some kind of a follow-up.
So just to clarify, we do have follow-up in the routine hospice after a death. We do follow up with families, but what we're talking about is maybe a separate, more specialized follow-up with families. And I'm sorry that that happened with your family, and thank you for sharing, and definitely we'll take that back.
Yes, please.
Let me, if I can, Lonnie Shavelson again. I may enter into deeper realms than we want to, but this whole question of opting out versus opting in, all fine, but the question is, when do you tell the patient? And so, for example, I think, Leah, you and I had a shared patient for whom they were about to be admitted into EOLOA hospice. And then they called me, and I called you, and we had the question that came up, which was the patient didn't know that by going to EOLOA hospice that you don't have a consulting physician working with the hospice. So the awkward position, of course, is when does a hospice let the patient know, a patient, not just this, that they're non-participating in essence because they don't offer the same services as in this case it was the hospice down the corner, where I was able to refer the patient, they got a consulting physician and could continue. And honestly, I don't know the answer to that question at all. I'm just bringing it up. The same thing for Providence is when do you tell patients when they come in that should they want the End-of-Life Option Act or aid in dying that you will not participate? When is it informed consent? Or when does the patient come in, such as almost happened with Leia's hospice, when does the patient come in and only later find out? And that delay, as we've all learned, is why patients die in the 15-day waiting period. It's not just the 15-day waiting period, it's how long it takes them for that first verbal request to happen to get to that 15-day waiting period. And is it fair to the patients to not front-load it, to not let them know as soon as they walk in the door whether you participate or not? Because otherwise the patients 20 days later, 30 days later, finally say to you, I'm interested in aid in dying, and only then do you say, we don't do that. Is that making sense as a question? I think it's a tough question. I again, don't know the answer, but I'm curious where you go with it.
I'm not sure I know the answer either, but it's interesting that you bring it up because I was sitting at the table with my colleagues, and there were also a couple of folks at the table who, from another hospice, who've seen about 25 or 30 patients this year who've accessed the Act. So, you know, I can't speak directly to that, and it did come up because we've probably had only a small handful in our hospice, which it's a rather significantly sized hospice, Trinity Care Hospice in the Los Angeles area. We've had a small handful of patients who have been pursuing that option through other healthcare systems that we've sort of supported along the way, but a very small handful. So I don't know if people just assume that because we're religious or Catholic that we're not participating. I'm not exactly sure what the answer to that is, and if any of my Providence peeps want to chime in, please feel free to do so, but it's a good question.
I'd like the answer.
Okay.
Brave soul.
Thank you. According to the California Supreme Court in the case of Cobbs versus Grant, the patient's right to self-decision is the measure of the physician's duty to reveal. That right can be effectively exercised only if the patient possesses adequate information to enable an intelligent choice. The test for determining whether that information must be divulged is its materiality to the patient's decision. So the bottom line is, if it mattered to the patient and you didn't tell them soon enough, then you blew it.
I'd just like to comment as well, and I misspoke because we also have a fair amount of dignity patients in our service area, and I misspoke. I didn't comment about that. And we have had patients with the dignity system who are looking for access to the End-of-Life Option Act, and we have not taken a position of finding physicians to have them participate with. But it was a very powerful phone call when Lonnie called me and talked to me about this patient and his activity to help support that patient. And I was so appreciative of the call because I would never have wanted to have a patient come on our service and then be distressed or disappointed or unhappy with us in the way that we were envisioning our role with End-of-Life Option Act. So I was appreciative of the call, and it prompted a fair amount of dialogue in our organization about should we somehow understand where we might refer. We haven't come to any answers on that, but it was I appreciated the call very much because I would not have wanted to disappoint any family, and so I appreciated the call.
You know, before you respond to that, one of the things that I wanted to at least put out here as someone that's sort of been at least involved with it as we knew the law was coming into effect and developing policy around this issue, is that I think that what happens in this first year may be very different in what happens later on, and what the first experiences are that we're having and that we're probably reporting on right now are not necessarily reflective of how things are going to be in the future, partly because I think things are shifting, and this is what was said to me from people who belong to states who have had this in existence for a longer period of time, where everyone's anxiety was extremely high before anything went into place, and they said, don't worry, that will go away. That you'll get more accustomed, you'll begin to understand how this works. So one of the things that I want us to think about, and one of the things that we're seeing, is that when people make these requests, I think that these later requests were in that earliest batch of people that we're talking about, but as it becomes better known, I think these conversations become part of the larger conversation of health and illness earlier on in the care of patients. And so patients may make decisions even about where they get care based on some of those kinds of things, but also in terms of, this is not an issue just about whether your health system participates, but an individual doctor within your health system that might be someone that you're strongly attached to that may not participate. And at what point do you find out whether that doctor is going to be there for you? So we get into many issues of who will provide that care for you. And what we're starting to see is that more patients, and I work with oncology patients, are having these conversations long before they actually might qualify for the act, but it allows some planning to take place. And I think it goes back to that issue of the gateway of the conversation, and maybe some of the things that we're seeing as distress in this immediacy of this first year may not be the same issues of distress that we may see at some point later on. And so I think it's important to note that where we are in the window of time and keeping that historical perspective.
We only have time, I believe, for one more question. Ira?
I was still responding to Dr. Shavelson's comment, which I think my understanding of the basic ethics, and I say that with trepidation, knowing there's card-carrying ethicists in this room, but is that the disclosure should be immediate, should be proactive, much like just disclosing what you do and don't do within any health system. So I do think it's important that a health system and certainly a hospice and a palliative care program be very clear up front so that they know immediately. And I would speak again for the voice that's not getting a lot of attention here, which is the patients who are already worried about hospice and palliative care, worried that we do this wink wink through a morphine drip or other ways and don't want it, but we still want to care for those people. So disclosing up front is I think ethically and clinically important.
Certainly, if we're going to minimize regret, which is one of the goals, I think, of palliative care in particular, our goal should be to give parameters around expectations. So I very much appreciate what you're saying. If we can be clear and set expectations, I think we're going to go far in minimizing some of the distress that you otherwise hear. I want to point out for those of you who are overachievers, we're going to be at 4:15 in our breakout session talking about providing support for providers, and we'll be delving even deeper into some of these psychosocial issues. And I believe now we go to break for 15 minutes. Please come back at 3:20. We look forward to seeing you then.